It was a great pleasure to be reminded about Train the Trainers course and all the great memories that we have of that time together. Um, it gives me, today I'll be speaking on, hang on one second, please, there, on the management of non-alcoholic fatty liver disease and risk factor stratification in primary care and when to refer to a specialist. I have no conflicts of interest to declare. By the end of the session, I hope that you will be able to recognize non-alcoholic fatty liver disease as the most common cause of abnormal liver tests and describe how a clinical pathway for primary care physicians can be used to identify patients who are at high risk for advanced fibrosis and when to refer to a specialist. First, let us start with some definitions. Non-alcoholic fatty liver disease, or NAFLD, is a spectrum of disorders, which includes simple fat in the liver, or non-alcoholic fatty liver. When there's fat with inflammation, it's called non-alcoholic steatohepatitis, or NASH. And we know that patients with NASH can progress on to develop fibrosis and ultimately cirrhosis. And although this was previously called non-alcoholic fatty liver disease, because the features on a liver biopsy were similar to alcoholic liver disease without a history of drinking alcohol to excess, the new and more appropriate term is now metabolic associated fatty liver disease, as this condition is associated with the metabolic syndrome. So the risk factors for non-alcoholic fatty liver are obesity, type 2 diabetes, and dyslipidemia. And we know that it's more dangerous to carry excessive weight centrally rather than peripherally because it's the central fat that's more pro-inflammatory. So in other words, it's better to be shaped like an apple rather than a pear. Or sorry, it's better to be a pear rather than an apple. The metabolic syndrome is defined by having 3 or more of the following criteria: increased waist circumference, high triglyceride levels, low HDL cholesterol, a high blood pressure, or a fasting glucose impairment due to insulin resistance. Now, we know that obesity is an enormous problem worldwide. In 2016, it was estimated that there were over 1.9 billion adults that were overweight, or approximately 40% of the population, both men and women. And over 650 million adults are obese, with the prevalence rate being slightly higher in women than in men. And more concerning is the worldwide prevalence of obesity has tripled between 1975 and 2016. And the Global Burden of Health Disease Study has estimated that 4.7 million people will die prematurely, or did die prematurely in 2017 alone because of obesity. In Chile, it's a similar problem as in other parts of the world, and it's estimated now that about 1/3 of the population is obese, and that rate has doubled between 1980 and 2014. And I read a recent report that you're expected to spend in your country an additional $750 million each year for the next 2 decades because of the obesity epidemic. In Canada, approximately 30% of adults are obese, and our neighbors to the south, the United States, has a really a large problem with obesity, with 40% of adults now being obese. And the National Health and Nutrition Survey has estimated that about 1 in 4 people will have fatty liver discovered on ultrasound, and that about 10% of the population will actually have an increase in ALT. And if you carefully exclude other causes, most of this, 3/4, are due to NAFLD. Now, what about the natural history of NAFLD? This is some very nice work from 2018, looking at the fibrosis progression rates in randomized clinical trials. And it's estimated that approximately 1 in 3 people who have Nafld will develop NASH. And previous studies have suggested that up to 30% of patients will go on to develop cirrhosis, similar to what Dr. Alter was mentioning with hepatitis C. However, if you look at the placebo arms of these randomized controlled trials, the rate of progression of fibrosis was much lower, with the risk of cirrhosis being estimated to be about 10% rather than 30%. So even if we take a conservative estimate that 5% of patients with a fatty liver will progress onto cirrhosis after 20 years, we know that within 10 years, approximately 2 to 3 of those patients, approximately half of them, will develop complications such as ascites, variceal bleeding, hepatic encephalopathy, which marks decompensation of the cirrhosis. And once this happens, within 2 years, half of these patients will require a liver transplant or they will die from liver failure. However, it's important to note that the vast majority of patients that have non-alcoholic fatty liver disease will not die from their fatty liver. Now, my city in Canada has approximately 1 million adults. If the population estimates are correct, that means we have 250 adults with non-alcoholic fatty liver and about 75,000 with NASH who have an elevated ALT. Now, this still results in a large number of people developing cirrhosis, decompensated cirrhosis, and liver cancer. Many of these are resulting in liver-related deaths. So although this is already a big problem, we know that a recent study published from my peers here in Canada has estimated that the incident rate of hepatocellular carcinoma, decompensated cirrhosis, and Nafld-related liver deaths will double between 2020 and 2030. So there's much more to come. So it's clear that we have too many patients to be seen by specialists. And therefore, approximately 5 years ago, we partnered with our primary care physicians in our city to develop a clinical care pathway that supports primary care physicians in their diagnosis and management of Nafld, and uses shear wave elastography to identify patients who are at high risk for fibrosis and who should be seen by gastroenterology or hepatology. Now, if you hold your camera to the screen, you'll be able to be taken to the link of our pathway that describes this in more detail. And we will cancel referrals that come to our hepatology clinic and where it's clear that the patient likely has non-alcoholic fatty liver disease, and we will direct family physicians to this pathway to help guide them in the care of their patients. Now, most patients will enter the pathway with a non-specific elevation of ALT, and it's important to note that the ALT differs from lab to lab and depends on the healthy population. There are gender differences, but we know from studies and the nice ACG clinical practice guidelines that a true normal ALT for a man is 30 and for a woman is 20. And we tell our family physicians that they should worry when the ALT is 2 times the upper limit of normal, where they should actually worry about 2 times the upper limit of true normal, which is actually the upper limit of normal in many labs. And typically the ALT will not be above 200 in patients with fatty liver disease. And it's always important to rule out other causes for the elevated liver enzymes. Now, patients can also enter the pathway by having fatty liver incidentally found on an abdominal ultrasound. And beyond Nafld, there are other causes of steatosis in the liver. Alcohol must be excluded by history. Hepatitis C virus, as we just heard, especially genotype 3, can cause steatosis, as can Wilson's disease. We know that starvation, total parenteral nutrition can contribute to fatty liver. There's pregnancy-related conditions, including acute fatty liver pregnancy and HELP syndrome. And some medications can result in fatty liver as well. So when I teach about how to work up a patient with elevated liver enzymes and screening for chronic liver disease, I usually do this in steps. We've heard about how common hepatitis B virus is and hepatitis C. In my country, it's possibly 1% of people are carriers of chronic hepatitis B. It's estimated that about 0.5% or 1 in 200 are carriers of hepatitis C. And because fatty liver is so common, think about testing for the risk factors for Nafld. Next, it's important to rule out genetic and autoimmune diseases. And we do that by doing iron studies for hemochromatosis, alpha-1 antitrypsin level, and ceruloplasmin. And the incidence of these diseases in my country are about 1 in 300, 1 in 3,000, and 1 in 30,000. And think also about excluding autoimmune liver diseases. And when all of these tests are negative, you can also consider thyroid disease or celiac disease as a cause of an abnormal ALT. Now, in my country, with an incidence of about 1 in 300 for hereditary hemochromatosis, this leads to a lot of confusion about what to do with an elevated ferritin. And most elevations in ferritin are actually due to chronic liver disease, with Nafld being the most common reason for this. But also alcohol, hepatitis B, hepatitis C, or other chronic inflammatory conditions can lead to the elevated ferritin. And because it's so non-specific, our recommendations in Canada are for family physicians not to order genetic testing based on an elevated ferritin alone. They should think about this if there's a positive family history, or use the transferrin saturation, which is more specific. So the next thing to consider is, do you need to worry about the fatty liver once you've ruled out other causes of the elevated ALT? And we know that Nafld increases the overall mortality, but as I've mentioned previously, the leading cause is cardiovascular disease. But Nafld is now becoming a leading cause for liver transplantation, hepatocellular carcinoma in my country and many parts of the world. And remember, it's the NASH, but not the fatty liver itself that results in the liver-related mortality. So patients who have NASH, elevated liver enzymes, should all be assessed to see whether or not they have fibrosis within the liver. So our pathway instructs physicians to take a history around alcohol use, potential offending medications, recommends some baseline investigations, provides guidance on lifestyle modifications, and then recommends shear wave elastography if you live in Calgary. And if you live in other parts of the province, we recommend the FIB-4 test, where access to shear wave elastography is less available. We also ask physicians to pay attention to the ALT and the AST, as well as the platelet count. And we know that the AST is typically higher than the ALT in patients who misuse alcohol. But in any other liver condition, when alcohol has been excluded by history, for example, in this case, primary biliary cholangitis, if the AST becomes higher than the ALT, it is a good marker for cirrhosis, especially when it's associated with a low platelet count that happens because of splenic sequestration of platelets due to portal hypertension. Now, there are different ways of estimating fibrosis using serum markers or elastography. And we've decided to use the FIB-4 score, which takes into account the age, the AST, the ALT, and the platelet count, and can be easily calculated on a medical calculator. Now, we have recommended shear wave elastography, although we use FibroScan in our liver clinics, just because this is available on ultrasound machines within the community. And it's a two-dimensional ultrasound technique similar to transient elastography. Now, we've recently published the results of more than 2,000 patients who have gone through our Nafld pathway, approximately half of them with elevated liver enzymes, and who were all assessed with shear wave elastography in the community. and almost 2,000 confirmed to have Nafld. Now, 92% of these were low-risk patients, and therefore referral to hepatology was greatly reduced by using the pathway. We found that body mass index, diabetes, and hypertension, all parts of the metabolic syndrome, were significantly associated with a high risk for having an elevated median liver stiffness above 8, which is what we use for a threshold for referral. But interestingly, elevated liver enzymes were not predictors of a high elastography score. Now, in a subgroup analysis of the patients who we had data to calculate the FIB-4 score, if we would have used the cutoff of 1.3, which is in our provincial pathway, this would have led to one-third more patients being referred to hepatology. And 90% of these patients would have been low risk on their elastography. So the low risk patients can be managed in their medical home with the primary care physician focusing on lifestyle modification, diet and exercise, targeting weight loss of 10%, which has been shown to improve both liver inflammation and fibrosis, as well as we tell physicians to consider vitamin E and omega-3 fatty acids. And they should undergo yearly monitoring of their ALT, screen for diabetes if it isn't present at baseline. And then in 3 years, they get recalled for a repeat ultrasound and shear wave elastography to see if they're progressing and need referral to a specialist. So I'll just finish by summarizing a little bit about the management of Nafld. In addition to diet, exercise, bariatric surgery can be considered, especially in the morbidly obese patient, but its safety in patients who have established cirrhosis is not clear. I'll mention some of the diabetic drugs which have been studied in patients with NASH but without diabetes, and I will review the things in blue on this slide in upcoming slides. Statins have not been clearly shown to improve fatty liver, but are important for cardiovascular risk reduction, and are generally safe to use in patients with fatty liver, but should be avoided in those with decompensated cirrhosis, where they can result in rhabdomyolysis. Ursodeoxycholic acid is not recommended based on a negative clinical trial. Vitamin E is recommended, but should be avoided in cirrhosis as patients in the clinical trials were not cirrhotic. And I will mention obeticholic acid. And we recommend that patients with fatty liver disease avoid heavy alcohol use, although there's some interesting results that smaller amounts of alcohol intake may actually benefit some patients with non-alcoholic fatty liver. And I will remind you, as I am drinking coffee right now, that epidemiologic studies have shown that coffee consumption reduces liver enzymes, reduces diabetes in patients with liver disease, reduces hepatocellular carcinoma, and perhaps mortality. And this association is strengthened by a dose response and the fact that coffee is better than tea. I'll quickly review a few of the studies. This Pivens trial from 10 years ago found that vitamin E, 800 international units, improved the NASH score on paired liver biopsies. Due to the double comparison, this p-value for pioglitazone was not considered significant, and there was no improvement in fibrosis with either of these drugs. And because of some concerns with vitamin E and associations with cardiovascular disease and prostate cancer, we tend to recommend a lower dose than that was used in this study, 400 international units daily. And remember, no patients had cirrhosis, so probably best to avoid in cirrhosis. Now, recently, the interim results of obeticholic acid in NASH were published. The study had 2 primary outcomes: NASH resolution without worsening fibrosis did not improve significantly in this study, whereas improvement in fibrosis without worsening NASH did. And conversely, just this year, semaglutide GLP-1 treatment for diabetes was published in the New England Journal of Medicine, and found that the exact opposite of the obeticholic results. NASH resolution with no worsening of fibrosis was significantly improved on the highest dose of semaglutide, but fibrosis improvement without worsening NASH was not found to be significant. So it remains to be seen how these drugs will be approved, or whether or not they will be approved for the treatment of fatty liver disease. So in conclusion, fatty liver is the leading cause of abnormal liver tests. It's an increasing burden of chronic liver disease and cirrhosis and the complications, but there are far too many patients to be seen by us as specialists in gastroenterology and hepatology. And therefore, it's important to have these patients managed in primary care. Primary care physicians have to understand how to rule out other causes of fatty liver and abnormal ALT, and they should assess fibrosis, we believe, if possible, with the elastography, and if not, at least use the FIB-4 score, and refer patients with advanced fibrosis where they can be considered for clinical trials. And the mainstay of treatment right now continues to be diet and exercise. And for non-cirrhotic patients, you can consider vitamin E. Again, a couple of key references around evaluation of abnormal liver chemistry and the guidelines from the AASLD on hepatology. And once again, here's the link to our primary care pathway. Thank you for your attention.